Yes, so it's my pleasure to introduce Samantha, or Sam Liu. She is Assistant Secretary with the Health and Human Services Agency here in California. And if you don't know, all of the state departments that have anything to do with health care or human services report up through Health and Human Services Agency. And we've had some great leadership from Sam's boss, Diana Dooley, who is the Secretary of Health and Human Services Agency. She has made end of life one of the priorities for agency. And Sam is the one who's been tasked here with part of her responsibility is how the state handles implementation or the new law with End of Life Option Act. So join me in welcoming Sam.
Hi, good morning, everyone. I want to take a big, deep breath just to unpack all of the conversations and acknowledge all of the different voices that we have in the room. And really, first and foremost, wanted to first thank the Coalition for Compassionate Care of California, UCSF, and UCLA for inviting the Health and Human Services Agency here today. We were invited to really present on the first 6 months of data on the Act, including its findings, and wanted also just to acknowledge that the groups here, the physicians, the folks who are really on the ground implementing, seeing the patients, you've been a key instrumental in the evolution of this law, helping craft it and making this statute apply broadly to Californians and to those families who are able to now choose their own path at the end of their life, while ensuring that there are the same protections and safeguards for patients, families, and the physicians. And it's no surprise, since I just walked in and this was my first day here as part of this convening, that there was much discussion and debate that is ongoing and continues over this End of Life Option Act. But at the core, the intent was to allow patients who are terminally ill to maintain that dignity and choice and that independence, particularly at the end of their life. So the CDPH report really collects the first 6 months of hard data following the Act's enactment. And before going really too much more deeply into the statistics, wanted to take a step back and provide a little bit more context and history, of which I'm sure many of you are already aware. So Assembly Bill 15, which was enacted as part of the second extraordinary session, actually created this End of Life Option Act. It was approved by the legislature, signed by Governor Brown in October 2015. It's similar to what we now know is in Oregon's Death with Dignity Act that was in effect since '94. And Oregon's data and processes actually informed much of California's statute. The Act allows terminally ill adults who are living in California to obtain and self-administer aid in dying drugs, and participation in the Act, either by physicians, providers, pharmacists, is wholly voluntary. So when it took effect in June 9th of last year, 2016, it actually made California the 5th state in the nation to have such a law. And as we had this discussion today, this intersection of social policy and where we fit into this broad intersection of end of life and their choices. Within the Health and Human Services Agency, there are actually a broad number of state departments that touch the people and the families in their lives, particularly to the missions, but really because of whom they serve. So those are departments like Social Services, Department of Healthcare Services, which does our home and community-based service waiver, the state hospitals, developmental services, and then outside of the Health and Human Services Agency, you have Veterans Affairs, the Medical Board. And what CDPH's role is to actually just post the physician reporting forms on that website, collect data from the forms itself, publish this annual report, and ensure that we are complying with all the relevant privacy requirements. So the first report was recently released last June 27th and contains only 6 months worth of data. We hope that because of the short time frame that moving forward all future reports are going to contain full year data. So the time period that we're going to be speaking about is really June 31st, 2016, up until December 31st of 2016. And the report includes information like the number of prescriptions that were written, the number of known individuals who passed using the aid in dying drug. Data in the report broadly shows that Between this time period, 258 individuals started that end-of-life option process by making 2 separate verbal requests to their physician at least 15 days apart. From that 258, 191 individuals received the aid in dying prescription under the Act. Of that 191, 111 people passed following the ingestion of the prescribed drugs. Of the 111, roughly 87.4% were actually 60 years old or older. 96.4% were insured. 83.8% were actually receiving hospice and palliative care or palliative care. And of those 111 individuals, a large majority, nearly 58.6%, actually identified malignant neoplasms, so various forms of cancer, as the underlying illness. Following that, 18% were neuromuscular diseases, so ALS, Parkinson's. And physicians, coroners, and medical examiners report that underlying terminal disease as the cause of death on the death certificate, and that data collection approach just complies with law, ensures that there's this reliability, and then maintains the confidentiality for data de-identification guidelines. And given the Act's really recent enactment date, we're just going to continue to monitor the implementation of it, attend convenings such as these, and really look forward just to learning more. So with that, I just wanted to open it up for any questions.
I'm Helene Starks from the University of Washington, and one of the questions that we've been hearing a lot about are the data elements that are under the law right now for the required data elements, and I'm wondering if you have a way to speak to processes about modifying those data elements, and one of the recommendations or one of the work groups that's coming out of this is actually thinking about how to expand that. It compared even to Oregon and Washington, the required data elements list seems a little thin, and wondering if you can speak to the process for if and when those data elements could be readdressed.
Thank you for that question. So given the Act's recent enactment date, we're still continuing just to monitor the implementation. We really encourage to have these conversations in those convenings and can get back to you about what that process would look like. But at this time, we're just continuing to see how the Act is actually being implemented.
Hi, Laura Petrillo from Massachusetts General Hospital. Thank you for your presentation. I want to reiterate Helene's comments and just kind of emphasize that there are a lot of pieces of information even already being collected on the physician forms, pharmacy forms, that isn't reported in the reports, and in addition, there are many things that people are interested in knowing. I think one of the things that you mentioned is seeing kind of how implementation is going and ensuring that these safeguards are in place, and we really have actually no idea about some of those things to the degree that they're even currently in the law. And so I guess I would hope that this is something that could be a dialogue, and would really actually appreciate more explicit instructions about how to do that. So I know that the medical board is part of who's been who initially developed the list of data points that are being collected and reported, and I just would love for there to be a plan for an open forum, so a town hall type or a dialogue or an open way for there to be an exchange between the people who are kind of thinking about this on the broad scale and kind of monitoring trends and the state, because the state dropped this law into existence, and then clearly people are scrambling to make these enormous systems that encompass a lot of aspects, and we want to know about them. So there's so much interest in that, and that's all.
Thank you. I see another hand. I'll certainly take that feedback back to the secretary. The conversations just about data and processes is obviously this huge groundswell in wanting to know more. The report itself complies with all of the explicit statute that was in law. And so I know there is obviously much interest about wanting to put in more of those pieces. I think that's just going to be part of an ongoing conversation. I'm not personally aware of any forums like a town hall where that type of feedback would be open, but would be happy to connect with you afterwards.
So Sam, in that same light, because I think as you have clearly said, the law requires X, you guys have done X. But there is all of the raw data from the forms. Clearly, you are not empowered by economic provision to do all the work. You don't have the budget to actually do the work. But I'm sure there are researchers that you could even turn to that are within the state system, so it would still somehow be state as opposed to independent completely. So if there's some concern of confidentiality or some concern of process through the UC systems or through or the CSU system, in which there could be access to actually have people who, by discipline, profession, and inclination, are interested in doing this work. So the idea of having a partnership between HHS and the research community seems like a no-brainer here.
Hi, I'm Ann Gordon with Kaiser Permanente in Northern California, and I'm wondering if there's consideration of moving to electronic reporting instead of paper and fax reporting.
I can't speak to that now, but I can get back to you.
Sorry. Thanks very much. I just want to second the comment about the involvement of the research community, which I think is something that we're all hoping for and aiming for, and we're going to really think seriously at this meeting about the common data elements. And we have copies of the form will be available for the session that where we're going to talk about that later. But I have a specific question about the issue of how the collection of information that got into your published report about race ethnicity in California, how that information got into the report, given that that information is not on the data collection form. Our hypothesis on the outside has been that you looked at the information on the death certificate as a way of getting that. But I just wanted to, I've spent sort of the last 2 or 3 decades of my career thinking as an anthropologist about the complex relationship between things like language, culture, ethnicity, race, and how those things get attributed to individuals into official records, et cetera. We know that it's very poor in health systems. We know that there are huge problems in how that gets done on death certificates. So I'm just curious as to what has the conversation been about how to actually collect that information, given that the one really unique thing about California in this whole domain is that we are an extremely diverse state compared to the other states that now do have, with the exception of Colorado, the other states are markedly not diverse. So that's my question.
So the question, I think, Barbara, was how did we collect the race and demographic information? And you're right, it was based off of what the death records were when the physicians reported them up, and then compiled that to make sure that there were data de-identification guidelines that applied.
Was there a conversation about the deficiencies in the death certificate in recording this kind of data?
I'm not the specific technical expert, so I wouldn't be able to speak to that.
Just to tag on to that, so if it's easy to get information off death certificates, I think we all understand that death certificates sometimes are not done correctly, probably with people with terminal illnesses that are availing themselves of this act. Probably the cause of death, as far as the terminal condition, is probably going to be more correct than your average death certificate. But I was interested in the place of death. I think that's probably usually pretty accurate as it's listed on the death certificate, and it seems like that would be a really easy element to add to your data collection, and I would just like to make a pitch for that because people are really interested in that.
Thank you.
Lonnie Shavelson. Let's see, having been at the bedside perspective always comes for me. I've filled out 57 of these forms now. And at the end of the forms, the final act, so to speak, are these survey questions. 7, I believe, and the survey questions, it's not clear whether the physician was asking the patient, I'm sorry, let me back up. The survey questions I think are very, very important because they're asking the patient's opinion about why it is that they chose aid in dying as opposed to some other unknown route of death. And so you are actually administering a survey, I think, at the bedside, and this is where I'm not clear, to the patient saying, is one of the reasons that you have chosen aid in dying a loss of autonomy? And it goes on to 7 similar questions, pain, suffering, etc. And I'm quite confused, actually, still, at this point in the game, whether I'm directly asking that of the patient, whether that's my experience, that I'm thinking, did the patient experience that? And then how much fudging can I do? Because loss of autonomy is a fairly indecipherable term to, I'd say, 50 to 60% of my patients. So I changed that to independence, immediately ruining your survey. And I also changed pain and suffering to 2 different questions, ruining your survey even more because I don't think they're the same thing. So, and then to find out when you reported the results, there's no survey result in your report. So are we doing this all for naught? Is it sort of an experimental part of the survey? Does the patient answer the questions, or is the doctor answering the questions for the patient? And how much fudge factor do we have? That's a lot of questions, but that speaks to the vagary of what is that about?
And I'm going to give you an incredibly unsatisfying answer since I am not a practitioner, but I will have to get back to you.
Can I just piggyback on that for one quick second? In Oregon, actually, for the first few years of the law, the Department of Public Health called every physician who was participating and administered those survey questions over the phone. And so they were asking physicians to surmise on the motivations of the patient in retrospect. So it wasn't actually direct interviewing of patients or families, nor were the physicians themselves necessarily asking those questions of patients and saying, I've got the form in front of me. After the fact, they were saying, I believe that this person felt this way because of loss of autonomy. So
In other words,
So we need to
we're
wrap
playing
this up.
telephone with the questionnaire. I'm sorry.
I think you've raised a lot of great questions for us to look at here, Lonnie. And I would just put a pitch in that to the extent that this group can come together with consensus on what should be added or reported, I think that it would be very informative to all of the state agencies. So I'm hoping that's something that can come out of our breakout that you're leading, right, Laura? Yeah, great. So thank you, Sam.